Thank you so much for this invitation to speak today. As mentioned, I will present to you some interim data from our Phase I study, BNT211-01. These are data from patients who are treated under the automated process, the Prodigy. We've previously published data on about 22 patients that were treated with the manual process. My disclaimers. I don't need to tell this audience that there has been a lot of excitement and very life-changing results for patients with B-cell malignancies and multiple myeloma based on treatment with CAR T-cell therapy that has resulted in a number of approvals for these drugs. And with that, there's been a lot of excitement for the development of CAR T-cell therapies in solid tumors. And you can see that there are numerous trials looking at a number of different targets. But you can see, and I think all of us are aware, that we haven't made the same headway yet in solid tumors. There are a number of different challenges that we are encountering with solid tumor treatment when thinking about CAR T-cell therapies. One, identifying the appropriate target, a target that's important for the malignancy, yet absent in normal tissues so that we can avoid on-target off-tumor toxicity. We've had some difficulty with CAR T expansion and persistence, and then the well-known hostile tumor microenvironment, which is not necessarily favorable for CAR T-cell therapies. So let me switch gears and share with you data that was presented at ESMO just a couple of weeks ago by Dr. Hannon. This is updated results from our, like I said, BNT211-01 Phase I trial, which is a first-in-human Phase I study that's evaluating the safety and efficacy of a CLDN6 CAR T-directed therapy and a CLDN6 encoding mRNA vaccine in patients with relapsed and refractory CLDN6 positive tumors. So CLDN6 is a oncofetal protein that is silenced in adults, and it is a protein that's involved in the formation of tight junctions. You can see that we've tested the expression of CLDN6 in adult normal tissues and found that this is absent. However, importantly for the development of a CAR T-cell therapy, it is present on a number of solid tumors, including testicular cancer, ovarian cancer, endometrial cancer, lung cancer, and a number of other rare tumors such as sarcomas. So based on this information, we developed a CAR T-cell for these patients. So in effort to attack the other, one of the other problems with CAR T-cell therapy in solid tumors, we've developed a CAR T-cell amplifying RNA vaccine, which we call CARVac, which is intended to re-expand the CAR T-cell after infusion, and then with time maintain persistence, which we hope will ultimately result in persistence of the CAR T-cell and maintenance of a response that may be observed. And so you can see the graph on the left, which presents the ideal scenario where the CAR T-cells expand and then are re-expanded and maintained over time as the mRNA vaccine is administered. This slide shows the schema for our study. So this was a 3+3 parallel dose escalation design where first patients were enrolled into the the monotherapy CAR T-cell arm. Once that dose was found to be safe, they were then enrolled into the combination with the mRNA vaccine. So the key enrollment criteria included patients with Claudin-positive solid tumors by IHC. They had to have at least 50% of tumor cells that expressed Claudin. And then they must have measurable disease and good performance status. The primary endpoints for this Phase I study are safety and tolerability, as well as to determine either the maximum tolerated dose or the recommended Phase II dose. Of course, secondary endpoints include response, duration of response, and disease control rate. The data that I'll show you includes patients that were dosed up to dose level 3 monotherapy, and we're currently enrolling patients in the combination. So this shows the typical schema for a cellular therapy trial. So patients are found to be eligible, they undergo leukapheresis, and ultimately, when their product is ready, they undergo lymphodepletion with Flu/Cy. They then receive their CAR T-cells, and then starting on day 4, and this is where things are a little different than typical CAR T-cell studies, they receive their first mRNA vaccine. This is then repeated 3 weeks later and given every 3 weeks for 4 additional doses, and then every 6 weeks. This slide shows the baseline characteristics based on a data cut in May of 2024. At this point, we had enrolled 78 patients. You can see on the left half of the chart, these are the patients that received CAR T monotherapy, and the right side of the chart are the patients that received CAR T plus the mRNA vaccine. You'll notice that in the mRNA vaccine group, we also did a little exploration of dose of lymphodepleting chemotherapy based on some toxicities we were seeing, but ultimately landed on the fact that patients actually did better when they received full dose Flu/Cy. So moving forward, all patients received full dose Flu/Cy. You'll also note that the majority of patients, although these are relatively rare patients, especially the testicular cancers, the majority of patients enrolled were either testicular or ovarian, and that's based on the high prevalence of CLDN6 in these patient populations. Just focusing now on CAR T-associated toxicities that were observed in this trial so far. Again, the patients treated with monotherapy CAR T on the left side of the screen and the combination with CARVac on the right. First of all, pointing out that although a little over half of the patients observed or experienced some CRS, this was, for the most part, grade 1 and 2. Only 2 patients had grade 3 or higher CRS. We saw very little ICANS at this point, only 3 patients, and this was all grade 1 and 2. We did see HLH and some patients with high-grade HLH. I'll point out that as we were observing this toxicity, we updated our management guidelines to the HLH if patients experienced HLH, and now after those changes, we're no longer seeing high-grade HLH. Moving now on to response. So this waterfall plot shows the best overall response for all patients. Highlighted in blue are the patients treated with at least dose level 2 and 100% LD. And you can see that the responses tend to cluster around those, either the dose of chemotherapy or the dose of CAR T-cell as well as receiving full dose LDC. But I'd like to point out that overall the response rate was 32% in this patient population with a disease control rate of 43%. But when you focus in only on those patients that received dose level 2 or higher, the overall response rate was 51.5% and the disease control rate was 84.8%. Given that we enrolled a large number of patients with testicular cancer, I'd like to just focus in on some of the response observations in this group so far. And again, a similar waterfall plot where we've highlighted the patients treated at dose level 2 and 100% LD chemotherapy, as well as the remainder of patients shown in the gray graph. You can see that for all patients, the overall response rate was 24% with a disease control rate of 56%. And if you just look at the patients at dose level 2 or higher and those who had received 100% LD chemotherapy, the overall response rate was 41.7% and the disease control rate was 75%. And now focusing in on ovarian cancer, again, we had 30 patients enrolled, 24 evaluable for response. And again, looking at the waterfall plot, highlighting the patients treated at dose level 2 or higher. You can see that overall the response rate was 33% with a disease control rate of 75%. And then again, just focusing in on those treated at dose level 2 or higher at 100% LD chemotherapy, the overall response rate was 58.3 and the disease control rate was 83%. The next really interesting question, at least I believe it's interesting, is what are we doing with this CARVac? Are we making a difference? And this is a little snapshot to what we may be seeing. I think it's too early to see any differences with response, but if you look at the CAR T PK, on the left side, you can see CAR T alone, and these are patients treated at dose level 2, which is where we're starting to see better expansion and better persistence in general. But then you look at the graph on the right, and you see the combination. We're starting to see that more patients are having persistent CAR T cells out beyond 100 days. So hopefully we are making a difference here that hopefully will also translate into more durable responses for these patients. So just some key takeaways. One of the things I think we'd like to highlight is that we have developed a CAR T-cell therapy, and we're developing a CAR T-cell therapy, I should say, for solid tumors that appears to have a similar safety profile as other CAR T-cell therapies in general. And the toxicity has been manageable, especially with modified management guidelines specifically for HLH. I believe we're seeing encouraging signs of activity. We've treated a number of different patients with solid tumors, including non-small cell lung cancer, and I highlighted the data with ovarian and and testicular cancer. But I think really interestingly, we're seeing a number of patients, 3 currently, that have had quite durable response. We've had 2 CRs that have lasted over a year and 1 PR. We believe that the CARVac is making a difference. We're seeing persistence of CAR T cells beyond 100 days. And as I mentioned at the beginning, we're enrolling patients at dose level 3 plus CARVac currently, and really looking forward to seeing the results for that cohort. I'm happy to take any questions.
Thank you. Thank you very much. First question.
Great presentation. Thank you very much. 2 questions. One is, you observed some short-lasting responses as well. Did you explore the mechanism of tumor escape, specifically if you were doing a biopsy, were you observing this the same target that you were aiming? And the second question, I think I've seen one pseudo-progression on your testicular cancer group. Could you explain a little bit about this patient specifically, if you remember?
Okay. I'll go back to the first question. So the first question was around tumor escape. Whenever possible, when patients progress, we ask for biopsies. And so far, I think we've only had one where we've seen loss of CLDN6 expression. And can you repeat the second question about this? Was it a super expressor or a super...
Pseudoprogression. A patient
Pseudoprogression.
who responded and progressed and then responded again.
I am not aware of that. And I'll admit, I joined BioNTech in June. And so if this happened a while ago, I apologize.
It's on the spider plot.
It's on the spider plot. Okay, I should have looked at that more carefully. Sorry about that. I will look into that and get back.
Okay, second. Yeah, please.
Great talk. Question back to the previous question. When you do the biopsies, were you able to see your CAR T cells infiltrating into the tumors, or can you share a little any information you have on those front?
Yeah, that's a very good question. I don't think we have that data yet. I'm sure that our translational group is working on that, but that has not been presented yet. And I remember now that patient. I believe that this may be a patient who progressed. It's possible. We had several patients progressed, were retreated, most did not have further response, but we did have one patient who then went back into response, and I believe that's probably the patient we're talking about.
Yep.
Yeah, Norbert Hilf, Imetics. I'm interested in the side effects you have shown, and I think also in your in the presentations from ESMO, it's not really clear whether the side effects come after the CAR T-cell administration or also after vaccinations, and of course that would be very interesting to know.
Right. So I think the typical sort of CRS around, within the first week. Patients are sometimes having fever after the vaccine, but when you look at the overall side effect profile for CAR T alone versus CAR T plus vaccine, we're not seeing a significant difference. But again, there are some hints that re-expansion after the vaccine is resulting with either mild CRS or infusion reaction, if you want to call it that.
Thank you.
Sure.
Second question, if possible. You mentioned that you changed the management of HLH later on. Can you elaborate on that, or is it top secret?
Oh, it's not top secret at all. I think this is important. This is based on a publication, Hines et al., where I'm sure many of you are familiar, where they really dug into review HLH and sort of define this as a CAR T-cell immune effector cell entity rather than one that I think we're more familiar with that has nothing to do with CAR T cells. And so early identification, treatment with anakinra, and it's typically completely separate from CRS. But jumping on this quickly really has made a difference. But I highly recommend reviewing that publication and utilizing that information.
Yeah, thank you.
Sure.
Thank you. Hi, over here. In the wings. Misty Jenkins from Melbourne in Australia. Great talk. They were both of my questions too about antigen escape and whether you looked at T-cell infiltration. So I'll ask my third question, which is around the appetite for... So in this case, the CARVac was used to prime the CAR T-cells, but I guess I wondered, taking that a step further, whether BioNTech now has an appetite to extend these studies and add in other peptide vaccinations in this kind of combination approach.
I think that's a very interesting question. I think there's enthusiasm about exploring other targets. We're not there yet, but I think we certainly are interested.
So I had a quick question. Hi, I'm Dave Reardon from Boston. I'm curious about the timing. Was there a rationale for a 4-day window? Did you look or explore other windows? What might you think would be kind of an optimal strategy to put these two approaches together?
A very good question. I was not in the room when that happened, but I think they had initially, the initial cohort of patients were given the vaccine later in the process, and I think ultimately it was the protocol was amended to administer the vaccine earlier, and I think they were able to see a better response in terms of CAR T cell re-expansion when giving the vaccine earlier.
Yeah, this is Wolf Brahman from TCurix in Würzburg. One question: when you looked at the PK of the CAR T cells, especially in the mRNA stimulated situation, did you look at the phenotype of the CAR T cells with respect to exhaustion markers, and was there correlation between exhaustion markers coming up and patients no longer responding or going into relapse?
Very good question. This is one that I've asked my translational research group to work on. We don't have that yet, but yes, this will be coming in the future.
Also a question, maybe I just missed it out. So is the plan to continuously give in this vaccine afterwards or to stop it after a while? Yeah,
so currently the patients will receive the vaccine for up to 2 years. Yeah, but I think that's another interesting question. Is it necessary for that long? But yeah. That's the current
necessary,
protocol.
but also, what about a safety profile? Because you're keeping on, making the body produce this, CLDN6. What is the natural receptor? What is the potential side effect?
Yeah, so good question. It's as I mentioned earlier, it's a marker that's not present on normal tissues. Currently, it doesn't appear that it's adding additional side effects, but you're right. Time will tell if there's any long-term detrimental outcome. So I think, it would be ideal to answer whether or not a full 2 years is necessary, but currently that's the protocol.
Okay. Oh, no, Andrzej.
Very short. Combining this with the vaccination approach, do you see any endogenous T-cell responses against your vaccination? And do you think this might also play a role?
Yeah, no, that's a very good question. We have not seen that, but yeah, very good question.